Morning, everybody. We're doing neuropathology for March of this month. I have some kind of bread and butter cases and some a little bit more interesting ones, which we'll talk about. I guess we'll go to the first one. This is a 25-year-old male who's a patient of Dr. Morcos with blurry vision, headaches, and a sensation of orbital pressure that he described. On examination, he had numbness in the V2 and V3 distributions, diplopia with lateral gaze, and no other significant past medical history. So I think I'm going to defer to, let's see, I saw Silva. Silva, are you there?
Yeah.
Can you give me a localization on this?
Looks like it's somewhere cavernous sinus or near the cavernous sinus. Looks like some sort of maybe a abducens pulse, and then like I said, V2, V3. So,
yeah. Okay. Good. Good. I mean, it's a little non-specific. So why don't you tell us about this? I've got the images up, just a contrast sequence in the bottom, and then the kind of mix of sequences at the top.
yeah, looks like an enhancing lesion centered, kind of on the lateral, maybe the lateral wall of the cavernous sinus there, extending kind of down in, into the middle fossa, flowing the sphenoid wing there, and also goes down to kind of compress the face of the fourth there. So yeah, a large contrast enhancing lesion, kind of centered on the cavernous sinus on the left.
Okay, and then the top right image, the I think it's the only coronal I have up there. Why did I show you that one? That one, that's like a real key image, I think, for especially for diagnosis. Like, what about that image is kind of important?
I mean, maybe it looks like it's eroding down into the bone there, eroding into the middle fossa, kind of abutting the carotid.
Yeah.
Not sure what you're getting at.
Well, so this kind of a coronal image where you're through the skull base foramina, and it's not really erosive. I'd say it's more expansive. Can kind of give you an idea of how to limit your diagnosis to lesions that would expand a foramen. And yeah, differential on this one.
Differential meningioma, maybe a schwannoma, as you said, expanding a foramen. Those would be the two highest things on my list.
Yeah, yeah. Okay, Dr. Saad, I'll turn it over to you.
Is this the first case on the list?
Yeah, I followed the order you gave me.
Okay, thank you. Okay, so this is a classic example of schwannoma. So one of the features of schwannoma is what we call Verroquet bodies, which are basically palisaded tumor cells around acellular fibrillary stroma. And also, it's not uncommon in schwannomas to have degenerative change. So here we have a clear cell and some foamy macrophages. These are very common in schwannomas. Another feature that is common in schwannoma is the hyalinized thick blood vessels, which I've illustrated some of them here. And back to the degenerative change, these can be really widespread in a schwannoma, as in this case. So here you have pseudocystic change, thick blood vessels, and in this area you have abundant foamy macrophages. They don't have any impact on the prognosis, but as a pathologist, we need to be aware of these changes so to avoid mistakes. In terms of atypia and pleomorphism, as common in schwannomas, there is always mild to moderate atypia and pleomorphism, but mitosis are absent and necrosis is absent. Since schwannoma is a tumor of the neural crest, it is diffusely positive for SOX10, which has a nuclear staining. So this is a schwannoma grade 1.
Okay. Thanks, Dr. Saad. So Dr. Morcos took this patient back to surgery and had a gross door resection. I'm sorry, maybe subtotal resection, and looks good. Again, you sort of see how this tumor has been extending down into the middle fossa, sorry, the infratemporal fossa, from the middle fossa, kind of giving away that it's probably following along one of the nerves, and kind of fitting with also his sensory loss pattern as well. I know we've probably covered schwannomas numerous times in neuropathology conference, but I think the value is pretty good, especially for people taking the board exam. So everyone should probably be pretty familiar with this. But if you're not, they're benign tumors of Schwann cell origin. They're the most common peripheral nerve tumor, frequently associated with NF2, but 90% of them are sporadic. Probably in this case is probably a sporadic case as well. And again, they're expansile lesions. They're not really erosive to the bone. They'll follow through foramen and produce this dumbbell shaped pattern you can see here on this spinal schwannoma, or even in the intracranial ones as they pass through Dorellis canal. They pass through the like foramen valley, things like that, and they give that dumbbell pattern. What else? I think that's. Oh no. So postoperatively, the patient did very well. He had some residual diplopia, but improved from prior. He had some left eye dryness. Michael Silva, could you tell us why that might be?
Maybe the genicular ganglion, or maybe the third nerve were affected.
Yeah. So do you know what nerve controls the sensation of your actual sclera in your eyeball?
Maybe one.
Yeah, it's V1. So a lot of times people will complain of left eye dryness, and it's really a sensation because they can't feel the dryness of their eye. They're not blinking enough. So that's a frequent complaint. As Dr. Saad mentioned, there's the histological features include verrucate bodies and the antennae A and B fibers. Again, I think this is pretty classic for board exam stuff. You see these all the time, and I think they're kind of an easy question if you just know this stuff. I've been through this myself with neuropathology several times now. Here's our slides versus just an example slide. You can sort of see the kind of classic appearance. Again, the verrucate bodies, these palisading cells, also kind of a dead giveaway. Here's the slide that Dr. Saad showed us compared to some just stock slides, and you can sort of see the palisading right along through here. Okay, let's go to case number 2. This one's a case of Dr. Komatar's. It's a 36-year-old woman who presented with dizziness, headaches, blurry vision. She initially thought she had migraines for several months and was managed for years really with her PCP with the migraines until someone finally ordered an MRI scan showing a pituitary lesion. The patient got started on bromocriptine, but there was no appreciable change in the size of the tumor, and she was sent for neurosurgical opinion. So let's see who we can. Oh, so on an exam, she has a right temporal hemianopsia and then a cell diplopia with far right lateral gaze. Let's see who my victim will be this time. Davik, are you on?
Yeah, I'm here.
Hey, Davik. Tell us what you think. You're at UMH. This is a classic UMH case, pituitary lesion.
Yeah, so there's an intracellular lesion that's eccentric to the right, just proximal to the carotid, and it's widening the cell a little bit. It would be like Coos grade 1 in this case, so findings would be consistent with like pituitary adenoma.
Yeah, so I would say the cell is not really expanded. It maybe looks a little like that on this CT scan, but you compare it to the ones you see with the big, even the other adenomas, this one I wouldn't say is particularly expanded. But otherwise, you were right. I mean, sort of eccentric to the right, fitting with the patient's symptoms. And I guess that's it. What about enhancement? What do you think about the enhancement?
So it's non-enhancing. MRI.
Mm,
Or,
what do you think about this?
it's pituitary stalk and pituitary.
Yeah, and this is a mid-sagittal image or a parasagittal image?
It's parasagittal. It's the ventricles aren't fully symmetric in that image.
Okay, yeah, it's I got it. Yeah, it's maybe a little parasagittal. It's as close to the midline as I could get it, but anyways, let's move on for a second. So I don't think I need to go through this, but the reason she has a temporal hemianopsia is because of a lesion compressing the optic chiasm, which produces the temporal hemianopsia. I'm sure we've all seen this. Everyone just took the board, so I'm not going to belabor this point, but a good diagram to know for all these different areas in the optic pathway and what type of visual deficit it produces. So the patient was taken for an endoscopic transsphenoidal pituitary resection because they were concerned about the diagnosis and her visual changes. They achieved a ghost shuttle resection and the visual fields returned to normal. And I will turn it over to Dr. Saad for some illumination.
Thank you. Okay, so this is the lesion. From the get-go, you can appreciate the presence of prominent lymphocytic infiltrate. And you barely see any pituitary parenchyma, at least not in this slide. So these are blood vessels, and everything in the background is small lymphocytes. This is another area of the lesion. You can, at the periphery, there is some residual normal pituitary tissue, but again, the parenchyma is replaced by this prominent lymphocytic infiltrate. I've seen so many lymphocytic hypophysitis, but the inflammatory infiltrate in this particular case was dramatic. So I ran it by our hematopathology colleagues to rule out low-grade lymphoma. And it doesn't look like low-grade lymphoma to their eyes. And this is another area of the tumor, which again shows you microscopic foci of residual pituitary parenchyma, but the vast majority of the lesion is actually lymphocytic. By immunohistochemistry, it's a mixed lymphocytic infiltrate, which is reassuring because if it was a neoplastic lymphoid process, it should be monoclonal and therefore should be either CD3 or B cells or CD20 or T cells. So it's a mixed lymphocytic infiltrate, and also out of caution, we did EBER to look for EBV-driven low-grade lymphoma, and it is negative. So this is an example of lymphocytic hypophysitis where the lymphocytic infiltrate is really prominent.
Okay. Thanks, Dr. Saad. Go back here for a second. Okay, so yeah, this is a case of lymphocytic hypophysitis. It's not actually a pituitary adenoma. Lymphocytic hypophysitis kind of falls under this umbrella of autoimmune hypophysitis, where you have two types, lymphocytic or granulomatous, lymphocytic being the most common of the two, where there's inflammation of the pituitary stalk with lymphocytic infiltration, as we saw on the slides. It's frequently the kind of buzz term here is when in postpartum women or middle-aged women are the frequent targets of this condition. Granulomatous is a little more aggressive, and there's not the same pregnancy association. Also, there's the markers that Dr. Saad mentioned that they ran are pretty important, and you'll see these show up in other types of pathology too, with the CD3 and the CD20, looking for these lymphocytes. So those are good ones to know. This is a table which shows the kind of differentiation between just an adenoma and a hypophysitis, which can sort of look like each other, just like we just saw. But as I sort of showed, if you look at the pituitary stalk, you see a thickened, non-tapering pituitary stalk, but that is midline. That's what I was trying to get at with Davik, but I guess the image wasn't super clear. And then classically, the adenoma, of course, erodes and expands the cellar floor, whereas in hypophysitis, it's more spared. And I'll show some images as a comparison. And then the enhancement, we'll go back to this as well, is a little more heterogeneous compared to the adenoma. So let's go to some slides. So here are the slides that Dr. Saad showed on the left side, and then some pituitary adenoma slides on the right. And I think you can appreciate the differences between the two. The ones on the left have this very clear lymphocytic infiltrate, which, you know, I think once you look at it, I mean, I guess I don't have the same experience Dr. Saad does, but I could believe this is probably very dramatic, the amount of lymphocytes here.
Yes.
Here's some images. The ones on the right are the case we're talking about, and the ones on the left are taken from a case I think was done last week at UMH, an adenoma. You can see the erosion and expansion of the cellular floor here. A little bit less intense contrast enhancement, also a little bit more homogeneous. This, again, you've got some dark spots. You've got big, very intense bright spots and dark spots. Here it's very homogeneous, but a little less enhancing than the lymphocytic hypophysitis. So again, back to this table again, just to kind of hammer in this point of the differences between the two, because it does make a difference, and it's clearly the reason why she wasn't responding to bromocriptine. This is not a malignant condition like Dr. Saad was mentioning, and so she was discharged and I think started on steroids. Okay, next case. This is a 37-year-old female who's presenting with a first-time seizure. Young, so she didn't have any past medical history. Never had a seizure prior to this. No childhood history. She was neurologically intact at the time that she was seen. She was not post-ictal by the time she got to the emergency room to see us. And we have this imaging finding, and I will defer to, let's see who's here. Damien, are you on?
Yes.
Yes, give us your impression.
So got T1 with and without images. There looks like there's a non-enhancing lesion on the left temporal lobe. And on T2, it looks kind of cystic in nature. In that center image there. Yeah, it also looks like there's maybe something on the right temporal lobe as well, kind of on the opposite side.
Yeah, I think that's just a misleading. Yeah, exactly. Okay, so let's go. What do you think? Differential.
Well, presenting with a seizure, I mean, I think like a low-grade glioma, given it's non-enhancing, like a 37-year-old. It could be like a ganglioma or something like that as well, in the temporal lobe, sort of cystic looking.
Okay, good. That's a good one. What if this person was younger? What do you think? Like if you temporal lobe, seizures, non-enhancing lesion, like a kid. Let's say a child. Oh, you haven't done peds yet. Who's done peds? Michael Silva's done peds. What do you think, Michael?
DNET, cortical dysplasia, something like that.
Yeah, those are good ones. Okay, and Damien, what's your plan? Should we do a VNS up front? VNS up front? Depth electrodes?
No, I mean, I think it's probably reasonable to assume that a lesion is the cause of the seizures in the left temporal lobe. You could do an EEG, see where the seizure focus is coming from if she's continuing to have seizures. But I think it's probably reasonable to assume that that's probably where the seizure is coming from.
Yeah.
So you'd want a diagnosis. So I think it's reasonable to offer resection of the lesion. They get diagnosis and remove the seizure focus.
Yeah, this is clearly they did EEGs, and this was localized clearly to left temporal lobe, and clearly a case of lesional epilepsy. She had some seizures, I think, after the initial one while she was admitted. So clearly a lesional epilepsy case, and a likely low-grade lesion. So surgery is the kind of next step here. So that's what was happened. Taken to surgery for a left temporal craniotomy with Dr. Komatar, and gross total resection was achieved. And I'll defer to Dr. Saad now.
Okay, so this is the smear preparation. First of all, you notice that if you go where the tumor is, the background is not fibrillary. There are some fibrillarity here, which are due to reactive astrocytes. But if you go away to where the beef is, so to speak, and you see the tumor cells, they don't have cytoplasm, and the nucleus has what we call salt and pepper, meaning finely granular chromatin with few small prominent nucleoli. And again, the background is kind of proteinaceous or neuropil rather than fibrillary. This argues against an astrocytic neoplasm. The permanent sections show the tumor that is composed of multiple pseudocysts, and we call them pseudocysts as opposed to cysts because the lining is devoid of any particular cells, meaning it's not epithelial or endothelial or any type of cells. It's just a fibrous wall. So there are several pseudocystic changes. Higher magnification. The tumor cells are similar to the ones we saw on the smear preparation. And this is the giveaway here. So you have a cystic space or pseudocystic space with a floating neuron. So this is the buzzword for DNET. This is a neuron with its large eosinophilic cytoplasm that is floating in this space. And again, there are so many other spaces in the tumor. By immunohistochemistry, the tumor cells are positive for a neuronal marker. This is a HUC-HUD, which confirms that these indeed are not astrocytes, but rather are neurons. Ki-67 is very minimal, is about 1%. So this is DNET in grade 1.
Okay. Thanks, Dr. Saad.
Mhm.
So again, Doctor, like we said, this is a DNET. What you see is these multinodule neuroglial columns, and frequently gets confused for oligodendroglioma. But again, I'm sure Damien knows what's the kind of classic immunohistochemical stain for that, right? The genetic marker for oligodendroglioma, correct? Damien, you can tell us, right?
That's like the 1p, the 1p19 Q correlation.
Yep, that's right. Very good. So, that's a big one for oligos. This one's associated with younger patients. That's kind of what I was getting at with Damien earlier. This is kind of a classic tumor of childhood with lesional epilepsy. Surgery is usually curative of both the lesion. Gross total resection can easily be achieved, and also obtaining Engel class 1 seizure control. Adjuvant treatment's not necessary and usually ineffective, and the imaging shows a bubbly appearance. This one's not quite as bubbly as some of them, and I'll show some stock film. But there's no contrast enhancement. Here's a couple of those. This one in the left has this very classic bubbly pattern. The one on the right is maybe a little more just non-enhancing single bubble. I don't know what you want to call it, but clearly temporal lobe again. They don't have to be in the temporal lobe. The most common location is temporal lobe, after that frontal lobe, but they can be kind of anywhere in the supratentorial compartment. And then this is our last case. This one's a little odd, I have to say, but it's interesting nonetheless. So this one's a 52-year-old male who had very severe hypersensitivity in his left thigh, pain, and then numbness below where his pain is. He didn't put that on his pain diagram, which was done in the clinic. He had no motor deficits whatsoever. And again, this decreased sensation distal to this area of hypersensitivity. Let's see here for a second. Here's his MRI scan. I'm not going to call anybody because I think it's already marked by the radiologist. but there's a contrast enhancing lesion here, sort of in the anterior thigh, in the fatty tissues. And let's see, what I have next. Here's the ultrasound of the same lesion. You can sort of see it lying within the sub-Q. Patient was taken to surgery. Lesion was excised. It was fairly easily accessible as far as I could tell, and was sent for pathology.
Okay, so this is the tumor at low magnification. The tumor is very well circumscribed, so you can appreciate the presence of this fibrous capsule all around the tumor. And also at low magnification, the tumor is very cellular, and it shows these blood vessels that some of them are what we call staghorn blood vessels, the same ones that you see in solitary fibrous tumors / hemangiopericytoma. Higher magnification, these are the blood vessels, and the tumor cells kind of arranged in nests. What nests are? Basically clusters of tumor cells that are separated by thin fibrovascular septae. And again, this is the capsule, and the entire tumor is confined to its capsule. In terms of cytology, there is no ATP and pleomorphism, no mitosis, no necrosis, and the tumor cells are kind of monotonous. They're all similar to each other. For us, this is a straightforward case. This is a glomus tumor, but how do we make this diagnosis? The most important stain is smooth muscle actin. So the tumor cells are diffusely positive for smooth muscle actin, and this is a glomus tumor.
Yeah, so probably not what we were thinking at the time of surgery. I think looked probably more like a schwannoma or something based on the imaging. Obviously, much more common. But glomus tumors or paragangliomas are WHO grade 1. They rise from the neural crest, and they are frequently associated with autonomic ganglia. You hear if they have parasympathetic and sympathetic components. Usually the parasympathetic ones are in the head and neck, whereas the sympathetic ones, which you probably know as pheochromocytoma, are in the retroperitoneum, and have catecholamine release sympathetic response. The cells are usually arranged into nests called Zellballen, and they have metastatic potential, although they're not technically malignant tumors. Here's a slide showing the kind of common locations for all these different types of glomus tumors. Carotid body is a frequent one. We have glomus jugulare we see a lot that Dr. Morcos takes out, and then the pheochromocytomas are very rare but frequently associated with VHL. Here's a couple example lesions. On the left is a glomus caroticum. You can sort of see it in the carotid bulb and displaying the internal and external carotid. In the middle image, you've got a glomus jugulare, again, enhancing lesion. And here's just a stock pathology slide of typical kind of appearance you might see on a written board exam. To really confirm what type of lesion this is, I mean, this lesion was easily accessible and probably not as the morbidity of going to take it out was very, very minimal. But in tumors that are a little more where the morbidity is much higher, just with the approach, you can pre-surgically diagnose the glomus tumors by specialized imaging, all of which are nuclear studies. There's several different ones, which actually I didn't really appreciate the differences between them all. But the dotatate scan is the most common one because it's tagged for the somatostatin receptor, and it's just the overall best scan that the radiologists use to pick up any type of tumor if they don't really know what it is. It works best for head and neck lesions, but it can work well for any location. MIBG, sometimes we see in the clinic. I don't think I see it as much as dotatate, but that one's more protocoled for pheochromocytomas and not as great for the head and neck lesions, which I wasn't aware of. And then FDG PET they use really only for if there's a concern for metastasis, as again these tumors have a propensity to metastasize, but again not malignant. And this is a paper that Dr. Gultekin, who did the initial pathology report, actually put in his report because of the kind of surprise of finding a glomus tumor in the soft tissues of the leg. But there's been a couple of reported cases of this in the peripheral nervous system of glomus tumors, and very similar markers to this tumor actually on one of the cases, and very rare indeed. I don't know if Dr. Saad, have you ever seen something like this before, or is this
something like what?
Like
Like
a glomus tumor in the periphery?
I've never seen it associated with a nerve.
Uh-huh.
Most of them occur in the in the hands, in the fingers, soft tissue. But this is the first time I see it associated with a nerve.
Okay, and that's all the cases for today. Thank you, everyone.
Okay, thank you, everybody. Bye-bye.
All right, thank you, guys. I guess we'll get started with my presentation early here. Can you guys all hear me?
Perfect.
Yeah, we can hear you.
All right, and everyone can see my screen here?
Yeah, you're ready to go.
Perfect. All right, so today, I think everyone here knows who I am, but my name is Greg Basil for those that don't, and today I'm going to be giving a talk about endoscopic spine surgery and developing a more nuanced understanding. Here are my disclosures. I think the beginning of this journey of endoscopic spine surgery for me traces back to 2019 when I took a trip to Germany. This is an actual photo from a dinner I had there in the brewery in the lobby of my hotel, but I wasn't actually there on vacation. I was sent there by Dr. Wang to begin to learn about endoscopic surgery. And I was very fortunate. I got to kind of travel all over the country, go to operating rooms, spend some time with some very productive endoscopic surgeons like Dr. Rolf Wagner. And I got to participate in some endoscopic labs there. So, of course, after 1 week, I came back an expert in endoscopic spine surgery. And of course, I say that facetiously because this is, a topic that, of course, takes much longer than that to become an expert on. But I was very excited about what I had learned. I wanted to share some of that knowledge with the residents here in Miami. And so I was very fortunate to be able to then host a lab in June of 2019, where I tried to impart some of the things that I had learned. And I recently went back and looked at a lot of those slides, and I don't think I said anything or taught anything that was misleading or incorrect, but I was very clearly in the very early stages of my understanding of endoscopic spine surgery. And so when I look back on it, what did I actually know at that time? Well, I knew some very basic endoscopic technique, and I think more specifically, I knew one specific methodology that was taught to me in Germany for one particular approach, which is a transforaminal approach. I had a conceptual understanding of the relevant anatomy, and I had a kind of a loose understanding of what the indications for these surgeries were. But I've spent a lot of time since then, talking to a lot of people that do endoscopic spine surgery, traveling and seeing other people do endoscopic spine surgery, going to labs kind of all over the country. And so I've learned a lot since then, and that's kind of what I'm hoping to share with you today. The first thing is kind of the foundational anatomy and why it creates challenges. And you'll see the anatomy itself is not complicated, but the interplay between the anatomy and the surgery can be. I've learned a lot more about critical hardware components. I really didn't know anything about the endoscopic hardware. And it's not a topic I want to spend a lot of time on today because it's kind of boring, but there's a few basic things that you should know if you're going to do endoscopic surgery. I've definitely learned a lot more about technical nuances and variations on approach and technique. I'm definitely beginning to understand some of the challenges of early adoption, and I expect to understand those even more as I go into practice over the next year. And then how to deal with common complications and advanced uses. And so, I don't think you can have this talk without talking about the rationale for endoscopic surgery and why it was developed. I think we all understand the concerns with open spine surgery. And of course, this doesn't apply to every open spine surgery, but people are worried about the high potential for high blood loss, risk of general anesthesia, the fact that there's muscle disruption, and this concept of loss of physiologic bracing of these paraspinal muscles, the potential for facet and ligamentous injury. And of course, related to the muscle disruption and the extent, depending on the extent of surgery, the slow, painful recovery and the challenging reoperations. And so when you think about this on a very high level, like how do you reconcile or address these problems? Well, one, you could decide to do less surgery. You could say, well, I'm scared of surgical complications, so I'm just not going to operate. Obviously, as surgeons, that's not our path to take. You could decide to do more surgery. You could say, well, because I'm worried about adjacent segment disease, I'm going to fuse everyone from the occiput all the way down to the pelvis. And of course, there's some people that do take that route. You could do more minimally invasive surgery, believing in the benefits of those over traditional open surgery. If you're concerned about general anesthesia, you could think about trying to do procedures that don't require general anesthesia. And then finally, you could kind of create a paradigm shift where you completely change the way you view spinal pathology and the treatment of spinal pathology. And I think, I'm not going to sit here and tell you that endoscopic surgery answers all these problems, but I think it's part of the solution. It's certainly more minimally invasive surgery in the sense that the incisions are even smaller. The muscle disruption is even less. Many of these surgeries can be performed without general anesthesia. And in some cases, people who are practicing the surgery view spinal pathology in a very different way than kind of the traditional way we've been used to, which represents a paradigm shift. And so I think the first question, this is for the juniors, is where do you put the endoscope? And of course, this is not where you put the endoscope. This is where a GI doctor, general surgeon might put it. But we put it here. And this is Cameron's triangle. Of course, as a triangle, there's three components to it. And so one is this exiting nerve root, which you see here labeled A. The next part is the descending nerve root or the thecal sac, which I think they've labeled B and D here. And then the last one actually isn't labeled here, but it's the superior aspect of the inferior end plate. And so there's your Cameron's triangle. And, you can look at that and understand it, you could look at that once or twice and remember those three components. But I think it's more important to understand why this can create difficulty. The first is that this is not really a potential space. If you think about general surgery and how they use the scope in general surgery, they have a big potential space that they can insufflate, they can view everything. With us, the anatomy is much less clear. That area has tissue over it. There's ligament, there's muscle leading up to it. Obviously, there's bone in that arena. And so the anatomy is certainly less clear than traditional endoscopic surgery. The other thing is that there's high value real estate in close proximity to non-deformable structures. Well, what do I mean? Obviously, as neurosurgeons, the highest value real estate are neural elements. And so we have nerves in close proximity to the non-deformable structure, which is bone, right? And so obviously you put another object in there and you risk compressing those nerves against that bone. The third point is that, to get to this space requires a three-dimensional understanding of the anatomy using only fluoroscopy. And we're going to spend some time talking about that today. And then finally, that triangle can be very difficult to access in certain patients, depending on the position of the iliac crest, specifically at lumbar 5, sacral 1, where the crest really often prevents you. Okay, so it's a little hard to do these things interactive virtually, but we'll try. Can one of the juniors, maybe Damien, can you tell me what this circle is on here?
It would be the exiting nerve root coming towards you.
Perfect. And then this triangle?
A traversing nerve root.
Exactly. So this is now this is a very nice, you're often not going to have a view that's this clean, but this is a beautiful view from an endoscope of this actual Cameron's triangle. And Damien got it perfectly. This is a triangle. Your exiting nerve root is here. Here's your descending nerve root. Your disc space is here, and that end plate would be right here. And this is just showing kind of where you are on a bony model. So, I said Cameron's triangle, but I think it's more appropriately referred to as Cameron's prism. And this is actually a really nice article written by Fanous and Dr. Wang. And they talk about this concept of this triangle really being a prism because, of course, this is a three-dimensional space. And while the thecal sac, the end plate, and the exiting root are the traditionally described Cameron's triangle, there's another structure that essentially forms the roof of that foramen, which is, of course, the SAP. And so when you think about this, understanding that the position of the SAP is really important. And so, the reason we call it or start thinking about it as a prism is not just to be technically correct, but because this has implications for the surgery. And we'll talk a little bit about that. So, the next thing is that when I came back from Germany, I had really only seen the transforaminal approach, which is really the workhorse of endoscopic spine surgery. But the interlaminar space is also critical, as I mentioned, especially for 5-1. You could see that that interlaminar space increases in size as you go down in the lumbar spine, which is very convenient to us because, of course, we cannot access transforaminally at 5-1, but we have this beautiful large interlaminar space. So we're going to talk a little bit about this interlaminar space as well. Again, relatively simplistic anatomy. I'm not going to actually make you guys answer this one. It's really the same anatomy, but just from a different view. This is the interlaminar view. And what you're looking at the top here where my arrow is, I think you guys can see that. It's labeled here anyway. There's the ligamentum flavum. Above that would be the lamina above. Here, inferiorly, you would see the lamina below. And this lamina goes down into the inferior laminar edge, which goes to the IAP. Here's your exiting nerve root. And here would be your Kaman's triangle. So this is kind of the view from an interlaminar endoscopic case. So that's kind of the basic anatomy. I think the next thing you need to understand about endoscopic surgery is that you operate underwater. And why do we operate underwater? I don't think there's any other surgery we do in neurosurgery that's done underwater like we do endoscopic spine surgery. And there's really two main reasons. The first is this, right? So if you look at this picture, you can kind of make out that there's maybe a checkerboard in the back, but the view is completely obscured by blood on the lens. And, as I mentioned, there isn't really a true potential space here. We put a dilator in, and the first thing you're going to see with your endoscope is a bunch of blood. And so the irrigation serves to clear that blood out of your field and allow you to actually see what you're looking at. The next is this concept of a third hand. And I Googled third hand and I found this guy, super weird guy. He basically developed his third arm and wanted to wear it on himself for the rest of his life, which is obviously impractical for a lot of reasons. He had skin breakdown and things like that, but now he does it as performance art. But nothing to do with endoscopic surgery. But in endoscopic surgery, we say that the irrigation functions as a third hand. So basically what that means is that once you open the ligamentum flavum, the irrigation will rush through that hole and push the dura away from you. And that's really important because that decreases your risk of injuring the dura, causing a durotomy. And I can tell you that's very real. We had a case of a durotomy in an endoscopic case here. And what we realized had happened was that the irrigation had run out. And even though it looked like there was irrigation in the field, it actually wasn't circulating. And so it wasn't having that effect of pushing the dura away. So very, very important. The other thing is that it can be used to temporarily tamponade bleeding. So if you have a bleeding area, the field gets clouded with blood a little bit, you can kind of plug the hole, look at where that bleeding site is, and then coagulate it. So the irrigation is very important. Obviously, you cannot do endoscopic spine surgery without it. The next is knowing your equipment. And I'm not going to spend time on these basic instruments. We all are kind of familiar with these: the needle for entry, our dilators, our working channel, of course, the endoscope itself, a bipolar and a monopolar. We usually just use a bipolar, and then Kerrisons and things like that. And of course, the tower, which has multiple components. But the most important component of your endoscopic surgery, of course, is your endoscope. And these come in a bunch of different forms. I'll show you that in a minute. But the basic components are the same. There's a working channel, which is where your instruments go through. There's your irrigation channel, and there's usually multiple of those, a camera, and of course, a light source. And this is the other end. And this is just important to know because, a lot of our scrub techs don't actually know how to set up the endoscopic equipment. So you have to be somewhat familiar. We usually hook up irrigation to one of these channels. We plug the other one because irrigation can come out through your working channel, and then you plug in your light source and your camera. There's two main types of endoscopes that are used: a rod lens or fiber optic. For your purposes, almost all the ones we use are rod lens system. The fiber optics tend to be a little bit more pixelated. And so, most modern endoscopes utilize rod lens system. I'm very briefly how it works. And I only talk about this because we're starting to do some work and thinking about enhanced visualization and lighting in endoscopic surgery. So you kind of have to understand this basic concept. But of course, the lighting source comes in, illuminates your cavity. Illuminated light is reflected back to the camera, and the camera processes the image and projects it onto the screen. And that of course is different than traditional surgery where we look through a microscope. We are familiar with doing things like that in cranial endoscopy, but it's different than most of the other spine surgery that we do. The next thing you have to be at least peripherally familiar with is this concept of optical angle and field of view. This is a really beautiful illustration that Suazo did for us for one of our papers. But basically, optical angle is the angle between the long axis of the endoscope, as is illustrated here, and a perpendicular line to the lens. Traditionally, it's about 30 degrees. They vary from 0 to 45, but most of them are 30 degrees. And of course, your field of view is your cone of visualization, which is dependent on your optical angle and your lens diameter. This is really important because knowing your scope, again, is 30 degrees means if you change the angle of your scope, obviously you can improve your visualization in various directions. You know, I mentioned there's many different types of endoscopes, and you know, a lot of this, of course, is marketing. I don't think that you need 10 different endoscopes to do endoscopic surgery. But we put this together for that paper I was mentioning on enhanced visualization, where we looked at all the different kinds. And you can see, in general, they're about 8 millimeters in outer diameter. Our working channels usually about 3 millimeters, and most of the optical angles are in the neighborhood of 30 degrees. The other thing is basic settings for your endoscopic surgery. There's not a lot of things you need to worry about in terms of setting up. But you know, I think everyone here could tell me what the average setting for a monopolar is, or bipolar in the spine OR. But I don't think that anybody, and I'm not going to quiz anyone here, but I don't think anybody could tell me the pressure you set to endoscopic, pump to, or the flow rate. And you have to know that because you're the one who's, like I said, most of the time you're the one who's managing this. And the pressure is usually about 50 to 60 millimeters of mercury, and the flow rate's about 0.4 liters per minute. You really don't want to go much above that pressure. The reason is, in general, you don't want that pressure to be higher than diastolic pressure to cause vascular compression. You need it to be high enough, again, to function as a third hand. So that's kind of the basics in terms of equipment and anatomy. I want to get into some of the approaches for endoscopic surgery. The first is a transforaminal, and I've put an asterisk here because there's a lot of different trajectories for this approach. I'm going to talk to you about kind of what works for me, but there's many, many different ways to do this. There's the interlaminar, which I mentioned we do mostly at L5S1. There's posterior approaches to the cervical spine. I'm not really going to touch on those today because they're really not very different than what you would do with a tubular case. And so I don't think it's that distinct to endoscopic surgery that we need to discuss it here. And then there's the transforaminal thoracic. I've crossed out anterior approaches to the cervical and thoracic spine because those aren't approaches, one, that I'm comfortable with, and two, that I necessarily think make a lot of sense at this point in time. So let's start with the transforaminal. I told you that's the workhorse. That's the most important one. So the first thing is, how do you position a patient? Well, you know, when I went to Germany, everyone there said, oh, you do these in the lateral position. Everyone does them in the lateral. Lateral is better because the foramen opens up, the dura falls away from you, there's decreased intra-abdominal pressure. And I think all of those things are true, but you know, I would disagree. And for myself, I think doing them in a prone position makes the most sense. I know Dr. Wang does them in prone. You know, most of the practitioners in the United States do them in prone, and there's good reason for that. One, positioning the patient in the lateral position takes a good amount of time, with this theoretical benefit being minimal. And I think that benefit is almost completely erased by the fact that you have to hold when you put the patient in lateral and do the surgery in lateral, you have to hold your endoscope upside down and backwards. And what that means is when you look on the screen and your hand, you think your hand's going forward, it actually is going backwards, and getting your mind to translate that and do the surgery effectively is very challenging. So I would advocate, certainly for people beginning to do this, doing this in a prone position. Most of these cases are done with local, although they can be done with neuromonitoring as well. Most of the textbooks say biplanar. Most of us don't do that. We just move our floor around from AP to lateral. And, you know, marking of anatomic landmarks is key. Now, you know, I think the most challenging part of a transforaminal endoscopic approach is just getting to the foramen and getting there safely. And so here I've put what's kind of a textbook description of how to do that. And after I kind of walk you through this, I'm going to tell you why, for me, this description is kind of inadequate. And so first, you know, the first step is always going to be, okay, know where your iliac crest is, because depending on how low you are, that's going to limit your ability to access that foramen. The second is to know where midline is, so draw a line along the spinous processes. Then you can mark the level of the disc space using AP fluoroscopy. And then the traditional teaching is you insert a needle about 10 to 15 centimeters off midline and direct it from superior to inferior, so a slightly downward trajectory, and you just get into the foramen, right? Sounds easy. But what's the problem with that description? Well, one, how do you pick that rostrocaudal direct trajectory? I mean, how high above the disc space do you start? You know, I said somewhere between 10 and 14 centimeters. Well, how do you decide whether it's 10 or whether it's 14? How do you understand your needle angle of inclination in terms of going anterior, posterior? And how exactly do you take these X-ray shots to guide localization? And so, you know, to kind of make this a little simpler, I've kind of drawn a mock-up here of how I do it and how I've learned to do it from other people over time. And I think this really makes it pretty systematic. So the first thing is you take an AP, and what I've marked here just for you to know is, you know, the roughly where the exiting nerve root will be. Of course, this is not exact. I just drew this in, but it's wrapping under the pedicle and coming out. And your goal when you get into Freeman is to be as far away from this nerve root as possible, right? So you want to enter, and I'll show you an ideal trajectory, but you want to enter at the very bottom of this foramen. And so the first thing you do is mark the disc space, and you do that by drawing a line across, you know, the end plate of the inferior vertebral body, and you just mark that all the way out. The next thing is you need your rostrocaudal trajectory. And what a lot of people do, and I think this is a really nice technique, is to draw a line from the inferior lateral corner of the contralateral pedicle to the superior lateral corner of the ipsilateral pedicle. And you just draw that line all the way out in the patient's back. And I'm going to show you in a minute what this looks like, the markings on the actual patient. So that kind of gives you your rostrocaudal trajectory, and as well as your up-down trajectory to the disc space. The next thing is, I mentioned, like, how do you know how far off midline to start? Well, what a lot of people will do is they'll take a K-wire or some flat instrument and put it on the side of the patient and take lateral x-rays until they see that instrument kind of touching the tip of the spinous processes. And they'll mark that line on the side of the patient as well. And that's your lateral starting point. So let me show you what I mean by that. It makes more sense in this picture. So this dotted line is the line that I showed you that you draw along disc space to midline. This solid red line is the line you draw from the contralateral inferior pedicle corner to the ipsilateral superior pedicle corner. And where this line intersects your dotted blue line is where you start. And the solid red line is the trajectory that you advance your needle along. So for me, that's kind of a nice systematic approach of doing it the same way every time. In terms of how you see this as you go in, you know, there's no right answer. I like to do it under AP. And when I get close to the foramen, but not in it, I flip to lateral. And you want to do that so you make sure that you're not too anterior posterior, because of course you can't tell that on an AP shot. You could also start under lateral and do the same thing and flip to AP. It's kind of dealer's choice there. But I think it's also important to think about, what does that final ideal trajectory look like when you dock your needle safely in a foramen. So I've put a suboptimal trajectory here and an ideal trajectory. You see the suboptimal, which is denoted by the red lines here. And what's suboptimal about this? Well, one, the yellow shows where the nerve is going to be, or roughly where the nerve is going to be. This suboptimal trajectory is too high in a foramen, and very likely with that trajectory, the patient's going to jump because you're hitting the DRG. So that's bad. The second is that in general, for the decompressive surgery, we want to start outside the disc space. And this one is starting within the disc space. And then finally, your goal is to dock your needle no more medial than the mid-pedicular line. So if you draw a line along the middle of the pedicle, extend it down, that's your perfect docking point. Any more medial than that, and you risk puncturing the thecal sac and causing a little hole that would be a durotomy before you even start your case. And so this green line is what you're really aiming for. You could see you're touching bone on the posterior superior aspect of the inferior end plate, and you're at the mid-pedicular line in the bottom of the foramen on AP. Once you've localized, from there, it's pretty straightforward in terms of getting to the next step. It's just a Seldinger technique. You put a guide wire in, you dilate up. And then I put in green this concept of reaming. This is plus minus, not everybody does this, but reaming allows you to open up the foramen. And I'm going to show you what I mean by reaming. I'm going to show you what a reamer is. So you may or may not ream, and I'll show you that in a second. And then finally, you perform your discectomy. I'm not going to spend a ton of time here showing you how to do a discectomy, because it's like showing you how to do a surgery without doing the surgery, and it depends on what the pathology is. But I will show you kind of some ways to orient yourself once you start this procedure. So this is what a reamer is. You can see it's a very sharp instrument. It only cuts one way. So if you turn it counterclockwise, it won't cut tissue. If you turn it clockwise and put downward pressure, it will cut through bone. And so obviously you're doing this before you put the endoscope in. So, a sharp instrument under, not under direct visualization has the potential to do serious injury to neural structures. So you have to be very certain of a couple things before you ream. one, that you're comfortable with your position in a foramen, two, that the patient is appropriately anesthetized. And by that, I mean that they're not so, the surgery is awake. And by awake, I don't mean that the patient's awake and talking to you, but they're awake enough that if they have, they're stimulated with pain, they'll let you know. So that's very important. But usually, if you know where you are anatomically, it is very safe to do. And what it does is it reams through the SAP and opens up your foramen and gives you a bigger working space. So this is what that kind of looks like. You start with your first wire, a rod in this case, you can ream, and then you put in your cannula. This particular case is doing 5-1, which again, I wouldn't recommend, I think certainly early on when you do this. So, I told you I'm not going to show you how to do the discectomy, but I do think there's one thing that you do need to be aware of. I think the key with endoscopic surgery, like every surgery, is being systematic, and you need to be systematic about identifying your anatomy. And Damien was very good at showing us and being able to identify that Cameron's triangle in an endoscopic view, but that's actually not what you're going to see when you first go in. It would be great if you did, because it would make your life super easy, but it's not. This is what you see when you go in, plus some blood. And this is what this view, and it's labeled here for you to see, what you're looking at usually at about 12 o'clock is your SAP. And obviously if your camera is directed forward, is your superior articular process. And here you could see cancellous bone, and that's because this bone has been reamed out. So that's what the reamer does. It opens up the space here. Inferior, and you see on the bone to the left, I've included that so you can understand what we're looking at, where we're looking at it from. That wraps around, of course, to the pedicle. So this will be your pedicle down here. And then above you, somewhere here, will be your axon nerve root. And of course, medially is your ligament. Once you take down that ligament, you'll see epidural fat and the thecal sac. And this then will be your disc space. So you need to spend some time stopping all the bleeding, identifying all this anatomy, seeing your pedicle, using your bipolar to clear it off and identify it. And from there, you can begin to do your work in your discectomy. And I think you can't stress enough the importance of identifying all this anatomy before you try to just jump into the disc space and take disc out. Okay, so you localize, you go in, you identify your anatomy, it's all straightforward, no problems. And, obviously in a perfect world, that would be true. But, like any surgery, there are complications associated with endoscopic spine surgery. And I think the one that we need to be most cognizant of are injuries to the dorsal root ganglion. And you see here in this cadaveric model, the DRG is pinned. And, Dr. Wang talks a lot about this DRG injury and how to avoid it. It is definitely a real thing. This is a multi-center review of 451 patients. In this review, 22% of their patients had immediately postoperative dysesthesia. Which, that's a high number. And I think, the number of patients who had it, who continued to have it at 2 weeks was much lower. It was like 5%. But it's clearly something we need to be aware of. In this study, they find no relation to the level of surgery. They found, of course, which is not surprising, that recurrent discs and foraminal disc had a higher rate of dysesthesia. And I think the last point I've highlighted, because I think it's really relevant, there was a statistically significant variation of dysesthesia across institutions, which speaks to the fact that there's probably some technical differences and some experience differences between the surgeons that are doing this and their rate of DRG injury. But, it's certainly a very real thing, which is not surprising, again, given this idea of neural structures in close proximity to bony elements. This is another one that I put up. I thought this one was just kind of funny. They looked at, I think, 16 patients, and they said that there was one patient that had numbness caused by DRG injury, but they say that the patient was relieved to be able to avoid open decompression. So they kind of write it off. And I think it's important that we don't write off DRG injuries, even if they are transient. We need to be aware of them. But, does that mean we don't do transfemoral surgery because of the risk of DRG injury? Of course, I'm going to tell you no, because I believe in endoscopic surgery. But it does mean you need to be aware of it, why it happens, and how you can avoid it. And I really like this picture. This is from the Atlas of Endoscopic Spine Surgery, which was written by Dr. Hofstetter and Dr. Wang. And there's some really beautiful pictures in there. If you're interested in endoscopic spine surgery, definitely recommend getting that book. But what this shows you is, if you look at this Cameron's triangle that I talked to you about before on a straight AP view, looking straight down at the patient who's prone, it's this big triangle that looks like you have tons of room. And again, here's a cartoon illustration, and you see that, descending nerve root here and the exiting nerve root in this beautiful triangle. But as you come from lateral, and I mentioned you're coming as far as 10 to 14 centimeters off midline in some cases, you could see that that landing zone looks much, much smaller. And if you look at the cartoon illustration, you could see that you're going to have to skirt right over the top of that nerve root to access it. And so how do you avoid DRG injuries? Well, the first thing is you can start more medial. Dr. Wang, likes to start more like 8 centimeters as opposed to the 10 or 14 that other people may advocate for that exact reason. Of course, if you start medial, you can run into facet, which will stop you from getting to the foramen, but that's okay because you just ream through it. We talked about that. The other is something that people like Dr. Hofstetter and Dr. Meng Huang are doing, which is what they call a trans-SAP approach, where you say, okay, well, I don't want to try to get right to the disc space. I'm worried about DRG. You can just land your needle right on the SAP right here, and then ream or drill through that. And that way you're nowhere near the nerve. And that's a very safe way to do it. And then finally, there's this question of neuromonitoring. Is neuromonitoring helpful? And so, this is a study that was done by Tony Young, who's an orthopedic spine surgeon, who's kind of a pioneer in the endoscopic space as well. And they looked at 65 patients, 32 who had actually neuromonitoring and 33 that didn't. And, I was kind of surprised what they found here. It's pretty impressive. 73% of patients showed a signal drop after initial positioning of their cannula. And they define that as a 5% increase in SSEP latency or a 50% reduction in amplitude. In 58% of these patients, repositioning did not improve these signals. However, in those patients, they went and did a foraminoplasty, which means reaming out to foramen, like I talked about, and then signals improved. And then in the other 42% of patients where repositioning was enough, it took about a minute for signals to go back to normal. But there seems to be some clear benefit to monitoring here. One, because they seem to be able to impact those neuromonitoring changes by repositioning their cannula and doing some other surgical maneuvers. And also this concept that, the dysesthesias in the neuromonitoring group were ultimately 1/3 the awake group. So not just the changes, but postoperatively the patients who woke up with issues. So only 2 of them in the monitored group and 6 in the non-monitored. So there definitely may be a role for monitoring in the future. And I know Dr. Wang and I believe Yingda are doing some work in terms of mapping the DRG, very similar to the way that we do when we do lateral approaches to the spine. So that's kind of the basic on the transforaminal approach. The other is the interlaminar approach, and I really like this approach. This is an approach that wasn't really taught to me in Germany, and I've learned since then. And it's generally used at 5-1, where there's a large interlaminar space, but it can also be done at 4-5 or 3-4, as long as there's a large interlaminar space. And this is the trajectory that you're looking at here between the spinous processes. And I think, again, if you just know the anatomy, it's super simple anatomy, right? The anatomy is not complicated. It's the superior edge of this window is the inferior edge of the superior lamina. Here you see the dotted lines. The inferior edge is the superior edge of the inferior lamina, and then laterally you're bounded by the IAP and SAP. And of course, there's no medial constraints to this window. I put this slide up because this was a slide that I gave in my presentation when I got back from Germany, because all I had was a textbook definition. And there's all this complexity in terms of where do you start for this approach, depending on whether it's axillary or shoulder. And what I've learned since then is that just overly complicates things. This is a procedure that you should do the same every time. And then once you're in there, you can easily access your pathology no matter where it is. And so this is what you do. Again, fluoroscopy is so critical to endoscopic spine surgery. You have to be able to manage your own fluoro machine, much like spine surgery in general. But the way you get to that interlaminar window is key. And so this is an illustration of how you do that. And so the first thing you do is you take a straight AP to find your level that you're trying to treat. And what you'll see is that this is your AP of the index level. And you see that your spinous process is completely over the disc space. And so what you do is you progressively angle the Ferguson on your machine from caudal to rostral until you're looking up that interlaminar window. And how you know that you're doing that well is that your spinous processes become centered over that disc space in that interlaminar window. So you see the difference between this X-ray where one spinous process is covering the whole disc space and this one where the spinous process above and below are straddling it. And now you see this beautiful, and you see it outlined here, this beautiful interlaminar window. You could see where your bone edge is. So all you do then is you put any object you want, needle or dilator, right just on the skin. You find this point, which is kind of halfway along the downslope of the lamina into the inferior articular process. And then you make a small incision and you go straight down to bone. You feel that bone, you feel the step off of bone, which goes into the interlaminar space. And then you put your working channels in. and you do your surgery. I wanted to show you what that intraoperative view looks like. In this case, they've already taken down the ligament, and you see the descending nerve root already here in this view. And what you do, basically, this is kind of like a Pen 4, like an endoscopic Pen 4. You basically push that nerve root out of the way, and you'll immediately see your, in this case, your disc herniation, which is a pathology you're treating. And it's very important, especially in this type of endoscopic surgery, but also in transforaminal, that you use your inner cannula as a retractor, and you accomplish that by rotation. And so once you push that nerve root out of the way, you can rotate your retractor, and now you have no neural elements, and you're just looking at disc. And so that's kind of the interlaminar approach. You know, it's also important to note that you can do a lot of other things endoscopically. And, you know, these presentations can get a little dry, talking a lot about theory and showing x-rays. So I just wanted to show you a quick video. I'm going to fast forward through it. I'm going to turn off the sound, and I'll just talk you guys through what's going on here. But this is a basically endoscopic hemilaminotomy and resection of a synovial cyst that Dr. Wang and I did. Let me just get right to the case. It's a 60-year-old male, and he basically presented with right lower extremity radiculopathy. Here's his imaging. You see this at 4-5, the synovial cyst, obviously on the right side. And so we elected to treat this endoscopically with endoscopic hemilaminotomy, resection of that synovial cyst. Here's our localization, very similar to what you would do for microdiscectomy. You know, you find a level of the disc, and we made an incision about 1 centimeter off midline. Again, very similar to microdiscectomy, a little bit more medial. And then the nice thing for an endoscopic surgeon, usually we don't have an arm that holds our endoscopic cannula, but for this particular case, there is an arm, and once you dock, you can lock it in. And now this is kind of interesting stuff. I want to show you what it actually looks like from an endoscopic view. Let me go back just a little bit here. So when you first put in your camera, this is what you see. You see a bunch of fat. Of course, you need to be careful that you know that you're not interlaminar or anything, but you always palpate down to bone. This is the endoscopic bipolar. And so you clean off all this tissue until you see the bone, which you see now. Once you've clearly identified that bone, you can put in your drill. And I'll tell you that this drill is probably one of the major shortcomings of our endoscopic surgery at the moment. It's a little bit underpowered, takes a little bit of time, but it's very safe. As you can see, it's a diamond tip. I'm not going to show you this whole video. Basically, you drill through that cancellous bone. Here you see the nice thin bone with ligament underlying it, and then we're going to pop through that. You can see right here, we're going to pop through. We're making sure that there's still bone there. It's not ligament yet. Now we're through. And actually, it's really nice here, and you'll see in a moment, you can actually see the delineation between the synovial cyst and the ligamentum flavum. You'll also notice how small the endoscopic kerasins are. So definitely doing some more drilling helps you to not have the surgery take super long. And then finally, in a moment, you'll see the synovial cyst will come billowing out here a little bit. I don't know if I skipped over that. Show that here. In any case, the rest of the decompression is kind of very similar to what you would be used to for a standard spinal surgery. Remove the bone, remove the ligament, and then ultimately you'll see the decompressed. That's kind of the last little bite, and you'll see the decompressed thecal sac, and we just inject a little Kenalog at the end of this case. You know, I think as you talk about more advanced uses of endoscopic spine surgery, thoracic transfemoral decompressions are very, very compelling. You know, all of the experienced endoscopic surgeons do these. And I think what's really nice is that we all know that thoracic discs can be very challenging. And the traditional way we do them, we often do transpedicular, sometimes they require fusion. But you can do this transforaminally just like you can do a lumbar disc. And it's a very kind of elegant way to get there. There's some slight variation on the lumbar transforaminal. One is that obviously you can't start as far lateral, because if you take that angle, you're going to go right through the lung and cause a pneumothorax. So you start more medial, usually about 6 centimeters off midline. And then there's the rib sometimes in your way, which can be reamed. And here you see the view that was taken by this endoscopic surgeon, you know, partial reaming of the rib there, and right to the disc pathology. Again, just to show you that trajectory, again, it's kind of along the SAP and kind of partially through this medial aspect of the rib. And here you see that pathology that you're able to target using this transforaminal approach to the thoracic spine. So, you know, besides the technical nuances of endoscopic spine surgery, we need to understand whether we think the surgery actually works. You know, what are the benefits? There's a lot of studies on that. This is one review of the literature. And, they found what you would expect, the same things that we find when we compare MIS surgery to traditional open surgery: shorter operating times, less blood loss, less operative site pain, better rehab than the traditional surgery. This is another review of the literature, and obviously these guys are probably a bit biased based on the title of the article, but what did they found? Well, and they were looking at traditional versus endoscopic approaches. They didn't find any significant difference in patient satisfaction. They found an earlier return to work for the endoscopic group. They find a slightly higher recurrence rate with endoscopic approach, which is not surprising. We'll talk about that in a minute, but improved outcomes in revision endoscopic surgery, shorter length of stay, and lower overall cost of hospitalization. So clear benefits to endoscopic surgery. But, I don't think you can talk about endoscopic spine surgery without talking about the learning curve that's associated with it. This was a study of one surgeon and his first 42 patients. And he looked at, he divided it into 8-month periods and looked at the rate of reoperation. And you see that there was a significant drop. By the third period, he had no reoperations, and by the second period, already had dropped. Now, he also decreased the total number of cases he's doing, so I'm not ignoring that. But clearly, there was a trend here, and he was reoperating because of inadequate treatment of their clinical symptoms. I think this study is maybe even more interesting. I don't think we can necessarily do a study like this in the United States. The study was done out of China. And they basically took two groups of surgeons, one who had basically no training in endoscopic surgery, which is kind of crazy, and another group that had 2 years of kind of instructional training, and then they just let them loose and had them do cases, right? And they compared them. So the findings on this slide aren't really interesting, right? It's like saying, like, if you had someone who'd never done a laminectomy and you put them against someone who did a laminectomy, like, obviously the guy who's learned how to do laminectomies is going to do better, which is what you see here. And again, that group A is the one who have minimal instruction. But this one is interesting. And so this shows the rate of reoperation. And you could see that the guys who've never even heard of endoscopic surgery before they do it had a very high rate of reoperation in their first 20 cases. So they divide this into the first 20 cases, the next 20, and then the last 20, so the 40th to the 60th. But by their third group of cases, by that 41 to 60th case, their reoperation rate had gone to 10%, which was the exact same as the group that had training. And so what obviously this shows is that this experience with endoscopic surgery is gained relatively quickly, but there is a clear learning curve here. And you talk to people who do a lot of endoscopic surgery, and that's the number everyone seems to say, about 40 to 60 cases to gain that kind of proficiency. They gave some tips that they learned in their study for overcoming the learning curve, which are kind of obvious: learning conferences, standardized surgical steps, mandatory cadaveric practice, and to pick easy cases for new surgeons. I think that also speaks to the value of simulation. This is an article that Damien, myself, and Dr. Wang wrote after I hosted that lab. And basically, it's a limited study. We held the lab, we had the residents fill out surveys, and we tried to understand how they felt about the synthetic model versus a true cadaver, what they felt to be the utility. This was a synthetic model. I actually had the department buy this after I went to Germany. I saw them using it there. It's got actual bones, in it, a spine in it that you can actually fluoro, and it has nerve roots and things. So it's really nice for practicing the approach. So we had a cadaver in the lab and we had a synthetic model, and we had the residents do both. And, again, limited, but we found that there was subjective improvement in resident comfort following the simulated model. And actually, I think more interesting, they didn't find a significant difference between a cadaver and a synthetic model in terms of efficacy as a training aid. Now, obviously, this lab was focused mostly on the approach. And I think as you get into the actual surgery, the cadaver is obviously much more useful than the synthetic model. But again, the approach is often the most difficult part for people to learn. The other thing is that, I showed you a good amount of literature that there was a significant rate of failure early on in these surgeries of reoperations. And we need to understand why that is. And so this study was looking at that. It looked at 55 patients who underwent reoperation after failed endoscopic discectomy to try to understand what happened. And, obviously they defined the grade of stenosis prior to surgery and the degree of migration. And you can see how they define high and low here. And they show you what they're defining as a high grade migration. And what they found is not surprising at all. The high grade canal compromise had the highest rate of failure, and the high grade migrations had the highest rate of failure, right? It's kind of what you would expect. They also hypothesized that in the patients with low grade canal compromise who had failure. The reason was probably because of incorrect localization or trajectory. In other words, the surgeon got a bunch of disc out, but it was probably central disc, probably wasn't the real pathologic disc. And, you know, in a high-grade canal compromise, they suggest things like wide annulotomy, nucleotomy to avoid this. They also suggest bilateral approach. You know, I don't necessarily agree with that. And I don't think any of the people that I know that are doing endoscopic surgery require that. I think it's just more comes with experience. But, you know, early on, it's not a bad idea to have some boundaries for endoscopic treatment of migrated fragments. So, you know, that's kind of endoscopic decompressive surgery. But, you know, you guys are all residents in Miami, obviously, where Dr. Wang has a tremendous presence here. And you know that endoscopic spine surgery is not just for decompression. So we're going to talk a little bit about endoscopic fusion surgery as well. This is an illustration. I love this picture from one of our papers. You see the patient actually flipped herself onto the table and she's actually giving a thumbs up before surgery begins. And so this surgery, as we mentioned, is done awake. And it's obviously done awake so that the patient gives us feedback when we're near the nerve root, which is very important so we don't give them a DRG injury. But also, many of these patients are elderly and can't withstand traditional general anesthesia. You know, you can't say enough about the importance of good anesthesia with this. Obviously, the anesthesiologist is walking a tightrope. The patient needs to be awake enough to let you know when you're near the nerve, but not so awake that they don't let you touch them, right? So that tightrope is very difficult to walk. Patient selection is key, obviously. And a very important point to note is here, the trajectory to the disc space is different. Even though we're going to the disc space, just like we do in a transfemoral, the trajectory is different. And this is, again, from that paper that I talked about that Fanous and Dr. Wang published, where they established different trajectories to the disc space and to this Cameron's prism. And this is what they call a 1A. So we would call our approach to a transfemoral decompression a 1B, and this approach to disc space for fusion a 1A. And what the difference is very simple. This is a parallel approach. And it makes a lot of sense, right? Your goal here is to get into the disc itself, get an implant into that disc space. So coming from rostrocaudal would not accomplish that very well, create some challenges. And so this trajectory is parallel. You're obviously, again, different from the transfemoral approach. You're actually getting into the disc space to start because your goal is to remove all of that disc. And again, I'm not going to teach you guys how to do an endoscopic fusion case, but this is, again, from our article that we wrote showing you the steps to this procedure. And basically the discectomy is accomplished using a number of instruments, including these backbiting instruments, wire brushes on drills, and ultimately placement of our implant. You know, we published the results of our first 100 patients. We're very excited. Patients did really well. There were 2 patients very early on who had graft migration. And obviously the process was revisited and revised. And what we discovered was that probably was from inadequate end-quit preparation. And so Dr. Wang introduced this step where he puts a balloon in, introduces Omnipic into it, and views whether there's residual disc material. Like you can see here, there's maybe a little bit of residual disc, and then that will have you go back and do more discectomy before you actually put the graft in. And after that, there were no further cases of cage migration. You know, obviously, like anything, there's challenges with awake spinal fusion. You know, your lordosis is accomplished via graft placement rather than graft selection because there's a limited number of grafts that are available for this right now. Misplaced grafts can be challenging to remove. You're relying upon indirect decompression. But of course, you know, and in some cases, we combine with decompressive procedures. So that's not really a limitation, just something to be aware of. And I think this final step is critical, that the speed in this surgery is kind of everything. You know, when you're an experienced practitioner like Dr. Wang, you can make the surgery look very easy. It can be done in an hour, you know, in a 1 level. But, you know, when you start doing this, obviously it's going to take you quite a bit longer. And so, you know, that can create a challenge with anesthesia because I mentioned they're walking a tightrope. They can only do that for a certain amount of time. So it just needs to be aware of that as you go to do these surgeries. You know, endoscopic surgery obviously can be combined with other technologies, you know, percutaneous robot screws, robot guided disc space localization, endoscopic discectomy, and SPECT scans to identify pathologic levels. You know, this is not a talk on using SPECT scans, so I'm not going to go a lot into that, but I circle that because I think it's very interesting. I think Roberto gave a talk on this 1 or 2 years ago. But, you know, we're not the first to do this. This was done by rheumatologists before. This is one study where they look at SPECT scans to target facet injections and show significant difference between groups. So it's kind of well established in other fields, starting to be used in spine surgery. And I think that represents the beginning of this paradigm shift where you can begin to say, okay, well, I have an 85-year-old lady who, true, she has scoliosis, but she's probably lived with that her whole life. Now she has back pain over the past 2 years. It's crippling. Do we have to treat that? You know, Jason gave a beautiful talk on sagittal balance last week and on all those parameters. And I think in many cases, we always have to be aware of that and understand it. In many cases, we'll treat it. But in some cases, you know, in these patients, we don't have to fully treat their pathology to make them better. And so you can think about using SPECT scans to identify pathologic levels, using ultra minimally invasive approaches like endoscopic approaches to treat them. This idea of modularization of fusion, where we don't necessarily have to be afraid, not that we want adjacent segment disease, but if you have it, that there's ways that you can treat that adjacent segment with different approaches that are not as difficult as traditional going through scar tissue. And this idea of pruning pathology rather than fully treating it. You know, this is probably the paper I'm most proud of in all my residency. It's kind of a philosophic paper called The Farmer and the Hunter. And I wrote it with Dr. Wang and JP, and we just talk about this idea of kind of being a farmer in spine surgery and kind of this progressive escalation of care. And sometimes that the big wins are not necessarily the huge big whack surgeries, but doing the small surgery that results in significant, meaningful benefit to the patient. And so, you know, I kind of give you a lay of the land in terms of where we are in endoscopic spine surgery now. Where do we go from here? I think we need to continue to recognize the value of endoscopic decompression for difficult pathology, like thoracic discs, like re-op spinal fusion patients with foraminal stenosis. Instead of thinking about maybe bringing them back for big surgery, think about sending them for an endoscopic surgery. We're beginning to talk about endoscopic deformity, and you know, some of you might think that's crazy. But we don't, and we're doing a lot of work to try to see whether this makes sense or not. You know, endoscopic ALL release. We've done some early work, myself, Vignesh, and Dr. Wang, on enhanced visualization and endoscopic surgery. You know, our cranial colleagues are using things like ICG, and can we use that in endoscopic surgery, maybe in re-op endoscopic surgery, to help identify neural elements from scar tissue? You know, integrating augmented reality. All these things are on the table, obviously in very early phases. But, you know, we're definitely doing the work. This is, I told you about the endoscopic ALL release. You know, we published this anatomical study as a first step in trying to think about this. And we actually had Roberto Perez Roman go to a lab and actually do an endoscopic ALL release. So we'll see where that goes. Maybe it'll bear fruit, maybe it won't, but we're exploring it right now. You know, obviously challenges going forward. I think it's really important to define indications and case selection. I think it's important to think about progress in our field versus just doing things because we can. Overcoming the learning curve we talked about. And this last one, I'm not going to talk about a lot, but maintaining control of our subspecialty. Anybody who does endoscopic spine surgery knows that there's non-spine surgeons, non-neurosurgeons trying to creep into this field, like pain specialists. And obviously we have nothing against pain specialists. Those are our colleagues. We work with them closely, but there's obviously problems associated with that. You know, I call this a Crystal Pepsi lesson, that not every new idea is a good one. And if you guys were a child of the 90s, you would know Crystal Pepsi. It fell out of favor pretty quickly. You know, I've used things like endoscopic approaches to the anterior endoscopic approaches to the cervical spine as being in that category right now. And maybe that won't be true a few years from now. But I think just because, again, we can doesn't mean we should. And it just as evidence of that, you know, this is a case that Dr. Levy, Dr. Wang are well aware of. You know, of a patient who came in having undergone, and Dr. Stark as well, who had undergone an endoscopic cervical discectomy by a pain specialist in outside hospital. And of course, when you think about percutaneously accessing the cervical spine, you can imagine all the issues. If you think about an ACDF exposure, she had this huge prevertebral hematoma, a carotid pseudoaneurysm, and you know, less is not always more. You know, I'm telling you all the virtues of small incisions with endoscopic surgery, but this incision on the bottom is her endoscopic incision, and this one is the incision we made, the large incision we made to evacuate her hematoma, and you guys could tell me which one of those looks better. So that, you know, again, all these things need to be counterbalanced. The last thing, you know, I want to very briefly touch on is dealing with common problems. These are the things you guys are going to see when you start doing these in OR. Hopefully we'll get to do a lot of these together. Hopefully we won't have a lot of patients jumping on the table, but if they do, as you're putting the needle in, that's a good indication. One, stop what you're doing, take an x-ray, see where you are. Very likely you're high in the foramen, and quite possibly you're starting too lateral. Again, the more lateral you start, the higher the risk of DRG injury. So just restart, find a new point, study your trajectory. If the patient doesn't jump on your needle approach, you get all your dilators in, and then while you're doing your discectomy, they start jumping. you need to take a look at your hands. And the endoscope can move very easily. It's not fixed to the table like when you're doing a microdisc. And so take an x-ray, very likely you're pointing your endoscope all the way up, maybe crushing that nerve against the pedicle above. So very often just adjusting your hand in that situation will fix the problem, but also make sure that you're not tugging on anything, that you've identified that nerve root. Bleeding obscuring your view, that's a very common problem. Again, you can block the water outflow. You can't do that for a long time, but do it momentarily. It'll allow you to see the bleeding area and then bipolar it and stop it. And then finally, if you can't get the endoscopic cannula immediately enough into the foramen, just ream. Again, if you know where you are, that's safe. CSF leaks, they're relatively uncommon in endoscopic surgery, but of course they do happen. How do you deal with them? Well, it depends on how big they are. You know, if they're small, usually just a piece of DuraGen will do. Small to medium, still probably a piece of DuraGen. If you start seeing nerve roots, probably needs to be opened. And of course, the larger ones likely requires conversion to an open surgery. To give you an idea of how common these things are, this was a study by Dr. Telfian, who of course is a leader in our endoscopic field. He's at Brown. He's been doing these for many times. So, you know, you can't take his rate of durotomy as what yours is going to be or mine is going to be. But, you know, in 907 patients over 4 years, he had 5 durotomies. And, you know, if you look at his study, none of them had any long-term sequelae, and most of them were treated just with onlay of a dural substitute. And I think that's it for my talk. You know, I put this up here because I think, you know, sometimes when we suggest spinal fusion to our patients, it's like a nuclear bomb goes off in their mind. And, you know, maybe we can offer them some alternatives before they get to that point or even after. Thank you, guys.
Great job, Greg. That was phenomenal. Learned a lot. I think the question I was going to ask, I think you addressed with your last slide, which is basically the rate of conversion to open, which I mean, I think that's probably an impossible achievement of Dr. Tefelian, or what, you know, yeah. He essentially never converted to open.
Yeah, and I don't, you know, again, that's not, you know, I would say, you know, you can't necessarily take that and extrapolate it to your own experience, but I would say, you know, most of the people I talk to, it is a very rare occurrence to get a durotomy that's large enough that it will require opening. There's a number of reasons for that. One, you have a very good visualization of what you're doing. And so if you get a durotomy, usually it's something very small. The Kerrisons themselves are small. And, you know, the way obviously to get a large durotomy would be to grab the dura and to pull up and not see what you're doing. That doesn't usually happen. So I think that's part of the reason. And again, the other being that the irrigation usually mitigates that. So, but, you know, there are cases, and, you know, I think we've had one here ever where we ended up having to open the case up. And in that case, the irrigation had failed it had emptied and hadn't been realized by the staff in a room. And so there was no hydrostatic pressure pushing the dura away. Thank you, guys.